Good evening, and thank you for joining us for another installment of our Ask the Doctor series. I am Titania Bailey, President of Arc of Knowledge, Inc. And for those of you that are not familiar with our organization, we are a nonprofit that provides resources towards building and strengthening relationships between our generations. And as a part of our generational health and well-being initiative, we have the pleasure of partnering with MedStar Health and their team of specialists to provide education and resources that promote better health practices. Our presenter for today is Dr. Alexandra Pratt. Dr. Pratt attended the University of Texas Southwestern Medical School and trained in internal medicine at the University of Maryland Medical Center. She completed critical care medicine training at the NIH and began her career at MedStar Washington Hospital Center in 2012. Dr. Pratt became physician executive for critical care medicine for MedStar Medical Group in 2022 and served as interim medical director at MedStar Southern Maryland Hospital Center from September 2022 to March 2023. She's passionate about patient-centered ICU care and developing technology to enhance patient and family experiences while reducing electronic documentation for ICU providers. She implemented a successful pet therapy program at MWHC, and her dog Cashew is now a certified therapy animal and canine volunteer for MedStar Health. She's a proud mother of 2 boys and an amateur road bike racer with a team in Bowie. Please welcome Dr. Alexandra Pratt.
Thank you so much, everyone, for having me. I'm going to try to share my slides here. Let's see how this goes. Now there's a button in front of me. Let's see. Share. Okay, if I go to this one and then do okay. Share, and then if I go to this one, what do you see now? Do you just see the slide, or do you see like all the extra slides?
I just see the slide.
Okay, right. Oops, sorry. Okay, so first question is, what is an intensivist? I get that question a lot. So an intensivist is a physician who practices in critical care in the intensive care unit. So we do extra training on how to manage the sickest patients in the hospital. And so I always tell people I'm the doctor you don't want to see, because it means something has gone horribly wrong. So we'll talk a little bit about cardiac arrest in the community, some myths about cardiac arrest, what happens after we do restart the heart when we are able to, a little bit about coma, and then a little bit more about critical care, and then be happy to take your questions about this or anything else. So myth number 1, cardiac arrest is not the same thing as a heart attack, although they are very similar. So a heart attack is like a plumbing issue. It's a blockage in one of the vessels of the heart that deprives that part of the muscle of oxygen. And a cardiac arrest is a stopping of the heart. Usually what we say is like an electrical issue, because there is actually a little electrical system that goes through the heart that causes it to beat. But a heart attack can lead to a cardiac arrest if the damage to the muscle is severe enough. So a cardiac arrest is when the heart stops completely. And for many centuries, this was also known as death, because when the heart stops, all the other organs in the body no longer get oxygen delivered to them, and they stop working as well. But for centuries also, people have been trying to restart hearts, and in the 1950s, this really started to work pretty, better than it had before. And so we created something called cardiopulmonary resuscitation. But interestingly, the first trial that was published on what we now call cardiopulmonary resuscitation, the outcomes were about 50% of people they were able to bring back. And in 75 years, we haven't really improved on that very much. So what are some of the causes of sudden cardiac arrest? So lots of things can cause the heart to stop, but this sudden cardiac arrest, the one that we're going to talk about mostly today, is often an electrical malfunction. There are some that are congenital. They're known as Brugada syndrome or Wolff-Parkinson-White syndrome. Electrical malfunctions can be caused by heart attacks, also known as myocardial infarctions. Old heart attacks can leave scar tissue that can disrupt the electrical pathways in the heart and make it more likely to go into a heart arrhythmia, which can then lead to cardiac arrest. Cardiomyopathy is when the entire heart is very sick and the muscle doesn't pump as well, and that can also lead to electrical problems in the heart. A lot of different medications can cause cardiac arrest. Ironically, some of the ones that we use to treat heart arrhythmias can also cause heart arrhythmias in the wrong setting and can lead to cardiac arrest. Recreational drugs, of course, cocaine is a big one for causing heart attacks and cardiac arrest. The opiates that we hear so much about, fentanyl and things like that, they can lead to cardiac arrest, but it's from stopping breathing because they suppress your respiratory drive. And then some blood vessel abnormalities or heart valve abnormalities can lead to sudden cardiac arrest. Myth number 2, there's nothing we can do about a cardiac arrest. And unfortunately, even when we do things, survival isn't that great, but there are things that we can do, and we'll talk about that. About half of out-of-hospital cardiac arrest, meaning any cardiac arrest that happens outside of a healthcare setting like a hospital, about half of them are unwitnessed, but 15% occur in a public place. But unfortunately, only 10% will survive. In the hospital, the outcome is a little bit better. About 25% of patients will survive. And that's because we have personnel that are trained in advanced cardiac life support. We're often monitoring someone's heart with the telemetry. So if they go into cardiac arrest, the response is immediate and fairly comprehensive. So that's one of the most important predictors of survival, is how quickly you can get to the patient and start resuscitation. So cardiac arrest can affect anyone, even children, unfortunately. These student athletes are one category. Affects people across age, gender, race, geography, and socioeconomic status. But unfortunately, it's not fairly distributed across all of those groups, and we'll talk a little bit about that. Out of hospital, about 350,000 patients per year suffer an out-of-hospital cardiac arrest, which is about 1 every 90 seconds. So it's pretty common, unfortunately. In the hospital, it's again almost another 300,000 per year with a survival rate of 25%. So, and I'll take, if anyone wants to pipe up here, this is my one quiz question. What is the one thing that anyone can do to double or even triple a victim's chances of survival in a cardiac arrest? Does anyone want to pipe up?
Does CPR work?
Yes, CPR is the one thing that we can do that can double or triple your chance of survival. Thank you very much, Dr. Hughes. I think you cheated. If there's an automatic defibrillator nearby, that can further improve a patient's chance of survival if it's used as soon as possible. So I have a video if you guys want to watch it on how to do CPR, but we can do it at the end also if you want. I can see if this link will work. Let's see if we can get it to go. You may have to suffer through an ad. Oh, it's not going to work. All right, we'll do it at the end. CPR is just one part of what the American Heart Association calls the chain of survival. And it starts, the blue circles here, the lay rescuer. That's anybody on the street who witnesses a cardiac arrest. First thing to do is call 911. Next thing to do is start CPR and then use a defibrillator AED if it's available. One important thing when you call 911 is to stay on the phone. This is something that our emergency response personnel have developed over the years, is the ability to coach people through the CPR, making sure that the scene is safe and helping to make sure that the compressions are adequate and all the things that when you're in a panicked state, you might forget even if you know CPR. The dispatchers are trained to keep people calm, help them get through it until the EMS can arrive. Then the EMS take over, patient gets to the hospital, then hopefully there's a recovery. That's the chain of survival. So our third myth, everyone receives CPR if there's a bystander. Unfortunately, we're finding out that that's not entirely true. So this was a study not too long ago done that compared the percentage of patients by race for receiving bystander CPR. And interestingly, even in cardiac arrests at home, Black or Hispanic victims are less likely to receive
Talking about
CPR.
it's cardiac arrest. Oh, you want to look.
And was that a question? Okay. And in public, unfortunately, the disparity is even greater. You can see here, again, the white people are in the blue and Black or Hispanic victims are in the orange. And there's a 10 or 20% difference in the percentage of patients that receive bystander CPR based on their race. So this is yet another example of some of the structural racism that we're having to fight. And we know that Black and African American victims are victims of cardiac arrest almost twice as often as white people. Men tend to have more cardiac arrest than women. Interestingly, women, if they do have a cardiac arrest, tend to be a little older and tend to not have a ventricular arrhythmia as their presenting rhythm. Usually there's just the heart stops altogether. There's no arrhythmia. Despite the fact that they're older and they have what's considered to be a worse initial rhythm, they tend to have the same survival rates as men. So women may be of hardier stock, but it's also been shown that women tend to get bystander CPR more than men. So unfortunately, it's not as evenly distributed as we would like. This is another sort of maybe a surrogate for other social determinants of health, comparing the state of Oregon to Washington, D.C., our capital city, looking at rates of cardiac arrest and then survival. Really interesting to me that in Washington, D.C., per 100,000 people, they have twice as many cardiac arrests than in Oregon. And yet, far fewer actually survive to hospital discharge. But if the arrest is witnessed and it's a shockable rhythm, things even out. So if there is someone there who can provide CPR and there's a shockable rhythm that they can get a shock for, then the survival tends to be the same between Washington, D.C. and Oregon. But the rates of bystander CPR are much higher in Oregon than they are in D.C. And again, looking at racial disparities in CPR and survival, we see that Black, African American, and Hispanic or Latino victims have lower survival rates than white victims. They have receive less bystander CPR, which we just said is the thing that can double or triple your chance of survival, and less use of an automated defibrillator. And so this is again really unfortunate. There's also some studies like out of Paris and the surrounding regions. They looked at the rates of cardiac arrest, and just the rates of cardiac arrest were much higher in the neighborhoods outside of Paris that were considered to be of lower socioeconomic status. And there were marked differences by socioeconomic status in the rates of cardiac arrest. So a lot to think about why that might be, but it's important for us to point it out. We know that CPR and AEDs save lives. I'm sure we all remember Damar Hamlin's dramatic cardiac arrest on the football field on live TV. He actually had a very rare cause of cardiac arrest called commotio cordis, which is a blow to the heart timed just right and just the right spot that can make the heart go into a standstill. It's incredible that he was back on the football field, I think just a few months later. And he used his voice to promote CPR training for everyone. What did Damar have going for him? Obviously, he's young, he's athletic, he had no underlying medical problems. And his team had actually gone through extensive training on cardiac life support, CPR, and he had all the medical personnel there. So he had everything going for him to give him a good outcome, but it's very fortunate. And he's used it as an opportunity to educate more people on the importance of getting CPR training, which is great. So what are some of the barriers to bystander CPR? Sometimes it's actually recognizing that a person is in cardiac arrest. You might think that they've fallen asleep or that they're just, something else is wrong. People don't always put it all together that this is a cardiac arrest. If you see someone who's unconscious, you can never go wrong by just starting chest compressions. If they're not unconscious, they'll push you away because it really hurts if you're not in cardiac arrest. So just do it, because if you're wrong, they're going to push you away. And if you're right, then you're going to save a life. One of the big barriers was mouth to mouth. Nobody wanted to do mouth to mouth on a stranger, right? That's ew. So it's actually been removed from the algorithm. So compression only CPR is what they ask bystanders to do. No mouth to mouth needed. It's just really important to keep the heart pumping. There's enough oxygen in the blood to at least buy us a little bit of time, as long as it's continuing to circulate. Fear of causing harm from the chest compressions. CPR is kind of violent. You have to press down and depress the chest by about 2 inches, which feels like a lot, and you're throwing your whole body weight behind it. It is a workout. No one should have to do it for too long, because you will get tired. You'll either slow down or your compressions won't be as deep. But people are worried that they're going to cause harm. You really, as long as you're getting that 2 inches of compression, it's very unlikely that you're pressing too hard. Go ahead and do it. And as fast as as is recommended, is about 100 to 120 beats a minute, which is pretty fast. And then not getting trained, right? Because who has time? But it's really, really important that we all have at least basic life support training. It's actually become the law in many states. And Maryland, fortunately, is one of those states that has a law that all high school students should get CPR training. And so we're almost at 100% here, as you can see in the map, which is great. So what is it exactly that happens after the heart stops? Well, the heart is there to carry oxygen and glucose to all of our organs, including the brain, take away the carbon dioxide and the waste products, and circulate them to the liver and kidneys. When the heart stops, there's no gas exchange happening. There's no more oxygen going to the brain. All of those cells in the brain start to die after just a few minutes. If we're able to shock or restart the heart, that's great. Oxygen and glucose can start going back to the brain, but now a lot of those cells have started to die and break apart. And those damaged cells, actually, when that oxygen comes back, it can cause more damage because it creates free radicals that can cause more damage to even the healthy tissues. So a free radical is basically a molecule that takes electrons from a healthy atom for themselves, and that causes damage to those atoms, which then causes damage to the cells. So who's going to get better after cardiac arrest? Even if we're able to restart the heart, not everyone really recovers from a cardiac arrest. Number one is the underlying cause. Whatever was going on with the patient that caused them to go into cardiac arrest is obviously not fixed yet. So if it's a really serious problem, they're going to have to continue to deal with that. Their age and what kind of health they were in before the arrest. Because if you are very sick and you have very little reserves in your organs because they're already so busy fighting off whatever other illness you have, they're not going to have the energy to also deal with the the huge insult of a cardiac arrest. How quickly we can rescue the person, how effective our CPR and defibrillation is, and then the post-arrest care. As I said, when we restore blood flow to those organs, all those damaged cells are circulating, causing more damage. And the only thing that we can do as healthcare providers is try to prevent what's called secondary injury, which is, another insult, maybe not enough oxygen because the lungs aren't working well and we're not delivering enough oxygen, not keeping the blood pressure where it needs to be. And so now the organs are again deprived of enough blood and oxygen. And unfortunately, about 10 to 16% of patients will progress to brain death, which is a permanent, irreversible condition that is where the brain has lost all function and it will never come back. And that's because as the brain, even if blood flow is restored, all those damaged cells cause swelling on the brain. The brain is in your skull and it can't expand with the swelling. So the only thing it can sort of squeeze out of the way is the blood. And so it squeezes those blood vessels shut, no more blood can get into the brain, and then the whole brain starts to die. And that's what brain death is. So how does age affect our outcomes? Interestingly, you can see here, this is your odds of a successful return of spontaneous circulation, meaning we've restarted the heart and the heart is beating again. They all center around 1, which means they're about the same at every age group, even up to 100 years old. We can get the heart restarted. That's not always the main problem, though. It's what the organs do once the heart is restarted. So as we get older, our chance of survival after a cardiac arrest, even if we are able to restart the heart, drops off precipitously around age 50. And even if we can have someone survive, what's most important to most of us is our brain's function, right? Do we have a good neurologic outcome? Are we able to interact with our loved ones? Are we able to speak, perceive the world, maybe even work? And that drops off really in the 40s, maybe early 50s. It starts to drop off precipitously until you get to the 90s when you have a 5% chance. And I think that when you get to be 100, you're made of pretty good stock. So that 5% chance is still pretty incredible, I think, if you're in your 90s and you've suffered a cardiac arrest, to have a good neurologic outcome. That's pretty amazing. It's exceptionally rare. So what is a coma anyway? We'll talk a little bit about how a coma is defined, what it means in terms of your prognosis or how you're going to do. Will you wake up or not? And some of the misconceptions that are out there in the media. So a coma is when the brain is shut completely down. It's not brain death because there's still blood flowing to the brain, but the brain is so stunned or damaged by whatever is going on that it is not functioning. And the way you see this, there's really no imaging test or even an EEG necessarily. Some EEG can sometimes tell us the brain waves if the patient's in coma, but really it's a clinical diagnosis. There's no response to the outside world. You can cause the person, which should be very painful, no response, not even the heart rate goes up. They will still have that respiratory drive because that is located so deep in the brain and it's protected that you will still have the drive to breathe, but you may not have the ability to cough up. If you have some mucus in your throat or something, you may not have the reflexes to cough it up, so you could choke. All the other body functions should still be normal as long as the breathing is supported. Coma, if it doesn't get any better, progresses to what's called a vegetative state after about 3 months. And this is where the brain sort of just reaches its new normal, which is not to say it's getting better, but some things start to return. The eyes may start to open spontaneously and seem like the person's awake. They seem to have a sleep-wake cycle. but there's still no response, no interaction in the outside world. There's some new research now that's actually starting to challenge this with functional MRIs, where they're able to see, even in patients that we think are in vegetative state, different parts of the brain light up to different stimuli, which means that there's something going on inside there, but we just can't see it. We can't get any interaction from the patient directly, but we can see it lighting up inside their brain. If there's some improvement, patients can progress to a minimally conscious state, which means they may have some ability to interact with the world. They may start to use, take a spoon and hold it like a spoon, or maybe recognize people a little bit. There's some interaction with the outside world, but they're not anywhere close to normal. And we talked about brain death. So coma is there's no response to the outside world, but your breathing drive, all of your reflexes are still intact. But just all the higher brain functions that we think of as our consciousness are not there. Brain death is the permanent, irreversible loss of all brain function, including the respiratory drive. So that's when the damage to the brain is total, and even that last drive to breathe is gone. And that actually is a form of death. And so even though a patient may be on life support and supported, they may still have a beating heart. And if their breathing machine is breathing for them, they will seem like they're alive. But because the brain is completely gone, we say the patient has died. That's really hard to understand for a lot of people. But it's unfortunately true. So patients who survive to hospital discharge after a cardiac arrest can have a meaningful recovery of neurologic function. We saw Damar Hamlin. They tend to be younger, as we said, less than 50 years old, tend to be healthier. Sometimes they'll require long-term rehab and care, and that's very expensive. Unfortunately, our healthcare system doesn't always provide all of the support that would be needed for patients to get all of the rehab and care that they might need for the amount of time that they might need. If they survive to hospital discharge, they will often, up to a quarter of patients will have significant cognitive impairments for months and months after discharge, sometimes years. Many of them, even if they seem to be completely normal, suffer post-traumatic stress, depression, anxiety, extreme fatigue. About 60% are able to return to work after about 2 years. So think about the impact that would have on your family, on your social functioning, if you weren't able to work for 2 years. This was a really interesting study out of Germany, where they took 113 patients who were vegetative or minimally conscious and put them in a rehab facility and worked with them. And over about 4 months, 22 of those 113 patients recovered consciousness, meaning they could recognize people, they had some speech, they could use objects functionally. Only 7 had a real functional recovery, where they were able to at least live independently, if not be back to normal, or made a full recovery, which is incredible. Again, these patients that made that full recovery were younger, and it took about 4.5 months to get there. Also of note, this study was done in Germany, which has socialized healthcare. And I don't know how that would translate to a study in the US where we have private insurance. It might not be the same, because this type of care would be extremely expensive. The same study, just looking at it in a different way, 76 out of the 113 patients remained in a vegetative or minimally conscious state. They didn't make any improvement. 15 of them died before they were discharged, and only a very small number made an improvement or recovery. But it's still incredible that they were able to make that improvement or recovery given the condition they were in when they started. So I think there is hope if you have a younger patient who was otherwise healthy and their other organs are functioning, the cause of the cardiac arrest is something that we can reverse. Given enough time, a lot of these people will make a really meaningful recovery. One of the things that we see in the ICU is sort of a misunderstanding or misconception of what's going on with a patient who's critically ill. And family members will say, oh, they're just tired. Unfortunately, that's often not the case. They are tired, but in many cases, they're also in a coma. There's two different big categories of coma. One is an induced coma, which is something that we do to the patient, where we give them medications to reduce their level of awareness because they're in terrible pain, or because if we can reduce their level of awareness, we also reduce their metabolic rate, and they're able to save that oxygen and give it to the organs that need it, and lessen the damage to their organs. Sometimes they're severely agitated and they're going to hurt themselves because of whatever's going on with them. And so we have to put them in a coma to try to protect them. Physiologic coma is something that is caused by the underlying illness or injury. In that case, unfortunately, all we can really do is give supportive care, help all the other organs function while the brain does its recovery, treat whatever is causing the coma, and then try to prognosticate, which means try to figure out how we think this person is going to do based on a lot of different factors. On the other end of the spectrum, from coma, there's something called delirium, which is an acute brain dysfunction where the patient is still conscious, but definitely not themselves. And sometimes this can seem like they're just really sleepy, and then sometimes it seems like they're very confused and seeing things, hallucinating, etc. All of these are encompassed in a term called encephalopathy, which just means acute brain dysfunction. And coma and delirium are just symptoms of encephalopathy. And encephalopathy means that whatever's going on in the body, this is how the brain is showing that it's suffering from the illness. Coma is a symptom, not a disease. So whatever is causing the encephalopathy and the coma is going to have a huge bearing on whether or not the person's going to be able to recover. So different types of comas, in a young person who's had a traumatic brain injury, they may be in a coma for some time, but we know they're going to recover. Someone who goes into a coma because they have devastating cancer that's consuming their whole body, they're not going to be able to recover from the coma. One of the big problems is, of course, how our media portray things like cardiac arrest and coma. Almost all of us, but this was a study of older adults, almost all of us get a lot of our information about CPR from watching TV, right? But unfortunately, the way it's portrayed, it gives us an overly optimistic view of what cardiac arrest is. Most cardiac arrests on television are due to trauma and occur in younger adults or children, far more than the elderly, but it's actually not that the opposite is true. The percentage of patients, someone actually did a study of this, watched a whole bunch of TV shows and looked at how many cardiac arrests there were and what the recovery rates were, show that about 75% of people on TV get return of circulation in a cardiac arrest, and 67% of them make a full recovery and are discharged home. So what the media portrays is something like this, and then 5 minutes later, they look like this. And unfortunately, that's just not true. And that's called the Grey's Anatomy effect. But this has real consequences. So in a survey of people over 70 years old, and they asked, what do you think is the likelihood that you would recover if you went into cardiac arrest and needed CPR? And as I showed you earlier, the chances of recovery drop off precipitously around age 50 or 60. 81% of people over 70 thought that their chances were better than 50% of making a full recovery. 23% thought they had a 90% chance of making a full recovery after cardiac arrest. So those are very optimistic numbers, and unfortunately, they're just not true. The chances of someone over 70 making a recovery are more like 20%. But it's important to know that the majority of patients will change their preferences for what they want when they learn the truth about CPR. When someone who's elderly learns that they're unlikely to survive and learns some of the trauma that can happen as a result of cardiac arrest, broken ribs, pain, etc., many will change their preferences to not want to be resuscitated. So if we have return of circulation after a cardiac arrest, the patient usually comes to the ICU if they don't immediately wake up. And some patients do immediately wake up. But if the arrest was prolonged, if there was delay in the CPR, in many cases, the patient will be critically ill. So what is critical care? Critical care is a part of the hospital where we can deliver far more advanced therapies to support a patient through their illness or injury. We use ventilators, also known as breathing machines, to help support the lungs. It pushes air into the lungs and then allows the air to come out. We can increase the amount of oxygen that's being given. That's through a breathing tube, usually through the mouth and into the trachea. We have circulatory support medications and devices. In many cases, someone who's critically ill, they can't keep their blood pressure where it needs to be. And so we have medications and even devices that can mimic the function of the heart to try to support the circulation. And then if the kidneys fail, we have what's called renal replacement therapy, also known as dialysis, which can be temporary in the case of an acute illness. And we can offer continuous dialysis to patients who are in organ failure. Got a lot of other tricks up our sleeve to try to support people through critical illness. All these therapies are extremely helpful and beneficial when they're used correctly, but there's also a lot of risk to all of them. So they require really close monitoring, and that's why we keep them in the intensive care unit. What else is critical care? Critical care is painful. It's scary for the patient and the loved one who is watching them go through this, and it's extremely difficult for everyone. The patient has to suffer their illness. The recovery can be long and very difficult. And the family members and loved ones suffer also because this is extremely stressful to see someone go through this. And patients can actually develop a form of post-traumatic stress disorder when they survive a critical illness. Family members do too. So there's we're learning more and more about what happens after critical illness to patients. You know, we thought they just went home and everything was fine. Turns out there's a whole syndrome of different issues that people have, from sleep difficulties, problems with their nutrition, their ability to eat. Sometimes the teeth fall out, vision problems, cognitive problems, loss of strength, because just being in a bed for even 2 days leads to significant loss of muscle mass. So they lose strength, they have joint problems. It's exceptionally difficult. And that's all comes together into something we call post-ICU syndrome, which is something that we're still learning more about and learning how to prevent. And there's a post-ICU syndrome family, which is all of the stressors that the family experiences when they have a loved one who goes through critical illness. Critical care is above all a team sport. We were doing multidisciplinary care before it was cool. We cannot do critical care without our nurses, obviously, respiratory therapists, dietitians, physical therapists, speech therapists, pharmacists, social workers. But most important is the patient and their decision maker, their loved one, who's going to speak for them when they can't speak. Nobody knows this person better than you. Nobody knows their preferences. Nobody knows their history better than you. And we need you to be engaged and giving us your perspective and hearing from us our perspective so that we can do our best together to care for the patient in the bed. And that's the most important thing, that we're all working on this together, and that you're sharing your perspective and we're sharing what we're seeing as well. Unfortunately, sometimes with critical illness, all the advanced therapies in the world can't always turn things around for someone. And at that point, there's no more therapies that can turn something around once it's past the point of no return. And that's when it becomes even more important to engage with the patient, if they're able to, or their decision maker, on what this person would want if they could be participating in the conversation. Because when we reach the limits of what our medical technology has to offer someone, we need to know what to do next. Because the number one thing we want to do is respect the patient's wishes, what they would have wanted. And that can be really hard, because sometimes we know that they wouldn't have wanted all these advanced therapies. They wanted to be at home. And that's when we have to speak for them and change our goals from trying to cure, because we know we can't, to trying to comfort. And just taking away as much pain and discomfort as we can for this person, so that they can at least live out the time they have left with some dignity, and free of pain. And that is something that we can absolutely do in every case, because we can always treat pain and discomfort, even when we can't cure someone. So that's it for my presentation, but I would love to hear any, how do I stop sharing? Not sure how to do that. Okay, I stopped sharing. Okay.
Thank you, Dr. Pratt, for that presentation. I am opening up the floor for any questions. Please, you can either enter them into the chat, or you can come off mute and ask any of your questions. I have like 4 that were sent directly to me. The first one was about medication use. What are the recommended medications during a cardiac arrest? And how has their use evolved with recent research?
Oh, that's a very technical question. So we have a limited number of medications that we can use in the cardiac arrest itself. So epinephrine is the big one. That's basically like one of the hormones that our body makes, adrenaline, and that can raise the blood pressure and cause the heart to beat harder and faster. So that's given. Other medications have come and gone through the algorithm, as maybe the evidence surfaces that it doesn't work quite as well. Vasopressin is a good example of that. That was in, then it's out. If you're able to get a patient on a monitor and there's a heart arrhythmia, amiodarone is often given to try to correct the arrhythmia. But all of that is advanced cardiac life support. And it's not something that we're going to be doing in basic cardiac life support. Chest compressions are the number one thing. All the other things are maybe helpful, but really the strongest data is just on CPR.
The next question was about post-cardiac arrest care. It asks, how do you assess neurological outcomes after a cardiac arrest?
Great question. So immediately after a cardiac arrest, almost everyone is going to have some encephalopathy, as we talked about, some brain dysfunction. How quickly they recover is probably a sign of, how long their downtime was, how good their CPR was, et cetera. If they remain in a coma, number one is we're trying to prevent the secondary injury. A lot of data around keeping the patient's body temperature, if not hypothermic, low temperature, at least normal, and avoiding fever, because fever is another big metabolic stress for the brain and the other organs. Once we have to give about 3 days after a cardiac arrest if a patient's in a coma. because we want to give that time for the brain to start to recover. After 3 days, we should start to see some indicator of whether or not the patient's going to make a recovery. And the recommendations now are to use as many different modalities as you can, because no one test is perfect for this. And we want to make sure that we never miss someone who is going to make a recovery, but because our test was off a little bit and it wasn't a perfect diagnostic test, we missed it. So the more different types of tests you can add to that, hopefully the better your prognostication will be. So there are some blood tests that are used, the neurologic exam itself, do your pupils react? Do you have a cough reflex? Do you have corneal reflexes? Those are really important. Do you have seizures? And EEG can look at the brain waves. It can tell you if there's seizures, and if so, those need to be treated, because even if the patient isn't having convulsions, they could be having brain seizures. Those need to be treated, and if they can be controlled, the patient might have a chance of waking up. Other signs on the EEG can show which patients probably just have such bad damage that they're not going to recover. Different patterns on the EEG can show that. Sometimes brain imaging is helpful, but we don't completely understand that yet. And so it can be one component of that, because there are some MRI findings that are really, really bad and mean that the patient's not going to recover. But everything in between, it's really hard to know what it means for the person, because the brain can heal to some extent. So as many of those different modalities as we can bring together, ideally. And we don't need to see like a full recovery to know if a patient's going to get better, but we like to see some signs that they're starting to recover. If we see that, then generally our recommendation, if the other organs are functioning and the underlying cause isn't something that's devastating, our recommendation would be to keep supporting this person, give them more time to wake up and see if they can get better.
And then the last question that was sent to me was about innovative techniques. And are there any being developed for cardiac arrest management that show promise?
I'm not aware of all the cutting edge technology. We have some machines actually that we're using now for long durations of CPR, because as I said, people start to get fatigued and they're not always perfect, especially if we need to support someone as we're doing a different life-saving procedure. We'll use a device that actually does the chest thumping itself. There have been improvements to the defibrillators and how they work, how they deliver the shocks. And then one thing that is being used more and more is what's called extracorporeal membrane oxygenation, or ECMO. That's basically a portable heart-lung machine, similar to what they use for cardiac bypass surgery, that actually mimics the function of the heart and the lungs by circulating blood through the body and giving it oxygen, taking away carbon dioxide. So in certain cases, we can use that to support someone until we can figure out what's going on, until we can see signs of recovery. If they're having a cardiac problem, we can support the heart until we can treat it or do a heart transplant or something like that if the damage to the heart is really significant. Does that answer the question?
Sure. Yes. And then there's another question in the chat. Can baby aspirin be used to prevent a heart attack or stroke?
So definitely want to take an aspirin if you're having a heart attack. And the literature is changing on whether or not aspirin should be used in all people. It used to sort of be that if you were old of a certain age, everyone should take a baby aspirin that hasn't been borne out. If you have certain risk factors, you should talk to your doctor about taking a baby aspirin every day, because it could prevent a heart attack or stroke. But we do need to be a little more thoughtful about that and not just give it to everybody, because it can also cause side effects.
Well, those were all my questions. Did anyone else have any other questions they would like to pose to Dr. Pratt? Okay. All right.
Why are they rethinking the use of aspirin? Well, when they did some really big population studies, they found that it didn't necessarily help if you didn't have the risk factors of, say, high blood pressure, diabetes, things like that. And aspirin is kind of like ibuprofen in that it can irritate the lining of your stomach and can cause ulcers. It also, the way it works to prevent heart attacks, it makes your platelets not as sticky, so they don't cause a blood clot in one of your heart vessels. So if you're prone to bleeding, that could be a bad thing. So just in large population-based studies, they didn't see a positive effect if they gave everybody aspirin, regardless of risk factors. So they're recommending a little bit more targeted approach. It's not necessarily directly harmful, but it just wasn't beneficial for most people. Okay, thank you so much for inviting me. This was super fun to put this talk together, and I really appreciate you guys, your time.
Yes, thank you, Dr. Pratt, for sharing those invaluable insights related to intensive care and cardiac arrest. And we hope everyone found this presentation insightful as well. Again, thank you to Dr. Pratt, the MedStar team, and our community partners for your collaboration on this important initiative, and to each of you for joining us. Of course, you can see the replay of tonight's session and any of our other Ask Our Expert sessions on the Facebook and YouTube pages of Arc of Knowledge and MedStar. So thank you all again for joining us, and enjoy your evening.
Thank you very much. Take care.
Bye.